if this is so obvious, which it is, um, how can everybody be wrong? And what we're talking about is a science which is not speculative, it's concrete. If acetaminophen has very little to do with autism, or maybe only induces a few cases, it's rare, then what all else must be true, right? And so then you have to start trying to explain all this evidence. Mine was 3.6 times more autism found in the women acetaminophen in their cord blood, and the autism was found in their offspring. So why, what is going on with that?
Welcome to Demystifying PANS and PANDAS, the podcast where we uncover the mysteries, breakthroughs, and hope behind these life-altering conditions. I'm Dr. Nancy O'Hara, a board-certified pediatrician, educator, and advocate with over 3 decades of experience helping children and families navigate the challenges of neurodevelopmental and neuropsychiatric conditions, especially PANS and PANDAS. These disorders can feel overwhelming, but here we'll break down the science, explore transformative treatments, and share stories of resilience and recovery. If you've ever wondered what's possible for your child or how to find answers, this is the place to start. Let's dive in. Welcome, everybody. It's Dr. Nancy O'Hara back for another episode of Demystifying PANS PANDAS. And I can't tell you how excited and honored I am to welcome William Parker to our podcast. William, I've known, admired, and learned from for the past almost 20 years. Dr. Parker studied biochemistry, microbiology, immunology at Duke for almost 30 years, and he's now a visiting scholar at the University of North Carolina in Chapel Hill. He's best known for the discovery of the function of the human vermiform appendix, which is a safe house for beneficial gut bacteria, and also is my main leader in helmet therapy. But for the last, William has been studying the impact of acetaminophen combined with oxidative stress on neurodevelopment, and his work is published on PLOS ONE, the European Journal of Pediatrics, Minerva Pediatrics, Clinical and Experimental Pediatrics, many other peer-reviewed journals evaluating the role of acetaminophen in the induction of autism. So, William, thank you so much for joining me.
It's a pleasure to be here, Nancy. Thank you for having me.
So this connection between acetaminophen and autism, what have you concluded about that?
Well, so we've concluded something that's much different than what you see in the mainstream news media, and that right now that you see in major medical journals. And it's the situation is almost surreal. I'll answer your question. What have we concluded? Well, the basic conclusion that we published, and we have ample data to support. I mean, more overwhelming evidence is what we call it, is that exposure of susceptible, and I underline and bold that word susceptible babies and children, and it can probably happen in utero as well, to acetaminophen triggers autism spectrum disorder. So that is the conclusion. There's a lot of nuance in there. Autism is very complex, and the susceptibility part of that, the acetaminophen part, not so complicated. Although what that drug does to the human body is very complicated. It's deceptively a simple molecule, but it does a lot of things in the human body. It works on fevers and pains through totally different pathways, for example. And it's just most of the debate right now is around some data. It's called a sibling control study, and they're getting exactly the results that we expect them to get. It's just, and they're saying, well, nothing to see here, but it's just like, wait a minute, the way that those work, and we can go into this, but the basically and just to put it in simple terms, they've adjusted out susceptibility. So what they've proven is that if you're not susceptible, say you're newborn and you're not susceptible, then acetaminophen won't trigger autism. That's what they've proven, but they don't understand their own results. We've proven this. We've modeled it mathematically. And on top of that, we've got about 30 lines of evidence now, and they're only looking at one line of evidence, and that one is misinterpreted. So it's just, again, surreal situation.
Wow. Well, I mean, we've always said genetics loads the gun, environment pulls the trigger. So yes, you have to have the susceptibility for the environment, in this case, acetaminophen, Tylenol, to cause damage. But, as long as I've known you, I have such respect for your following and leading the science. So what is that evidence that you have that supports the conclusion of this connection between acetaminophen and autism?
Yeah, I think it's real important just to when answering that question to start out and say most of the evidence is not from my lab. So,
Right.
there's 30 lines of evidence right now. We published a list of 24, but that leaves 6 more lines that have been published. We just haven't put them in a published list somewhere. So, if you look at that list objectively, maybe 5 or 6 are ones that my lab had a lot to do with, or at least something to do with. But if you break that down, you can sort of put it in different categories, the evidence, and one of the main categories is the toxicological data, just toxicology, right? So we know that acetaminophen, a certain percentage of it, even in healthy adults, forms a toxic metabolite. It's extremely toxic, and you need the master antioxidant glutathione to neutralize that. So what that means is that for anybody who takes acetaminophen, if you have oxidative stress, if you're lowering glutathione, it's going to make acetaminophen more toxic. And that's what you
Right.
see with autism spectrum disorder and the conditions you work with in your practice largely is that the kids have a lot of oxidative stress, which means that acetaminophen is more toxic to them. So the mechanisms make sense, and then just some really interesting data out there that have been known for decades. For example, that domestic cats, every veterinarian knows domestic cats cannot have acetaminophen because they're missing a certain, let's call it a safe metabolic pathway. There's unsafe metabolic
Hmm.
pathways which give you the toxic intermediate. It's called a quinonamine or NAPQI, is generally what it's called. And then there's safe pathways, and cats don't have one of those major safe pathways. There's two of them, sulfation, glucuronidation. Cats don't have the glucuronidation, so they can't have acetaminophen. Every veterinarian knows this. Now, most pediatricians don't know that newborns don't have glucuronidation, so they're missing one of the same pathways, and that's just another line in sort of the toxicology evidence. Laboratory animal studies tell us that there's a whole issue with assumptions. And if we look at the history of the science, and in the 1960s, it was assumed that babies were just small adults, and if we wanted to monitor for the safety of acetaminophen, commonly known, brand name Tylenol, what we would do is just check for liver function, because in adults, if you or I take too much acetaminophen, it's not going to be good. It's going to kill our liver and we will die from that. But they assume that that was also true with babies. So they only monitor for liver function. And it turns out that is not correct. In
Right.
laboratory animals, and this is so I've got the background on the one of the next pieces of evidence is that in laboratory animals, we know that newborn laboratory animals, you can give them so much acetaminophen that they die and it doesn't hurt their liver. So it's in
Wow.
newborns, it's the target organ is not the liver, and we now know that it's the brain. Laboratory animal studies show that just small doses of acetaminophen, close to what we're giving humans, will cause permanent neurological impairment in laboratory animals, which means the drug could never be approved today. And that's
Right.
just there's studies in lab, and then there's a whole pile of miscellaneous information. One really interesting miscellaneous scientific observation is that in adults, acetaminophen blunts social awareness. And there's only if almost that's just sort of some obscure. There's 3 or 4 labs that study that, and it's kind of
Wow.
it's telling us that acetaminophen somehow is targeting the parts of the brain which are affected in autism spectrum disorder. That's another miscellaneous line of evidence is that fetal alcohol spectrum disorder is very, very similar in many ways to autism spectrum disorder. Clearly, they're different, but they're sort of like two
Right.
peas in a pod. They're not the same pea, but they're very similar. The drug alcohol is very similar to the drug acetaminophen. Both of them treat fever. Both of them treat pain. They're both metabolized into a toxic metabolite. In fact, it's the same exact enzyme that metabolizes them into a toxic metabolite. So, well, for the most part, that's true. But there's a lot of nuances there. There's many enzymes that can convert, not many, there's a handful that can convert acetaminophen into a toxic metabolite. But so you've got the miscellaneous, and then you've got these associations in time and space. All right. So if you look, for example, with Orthodox Jews who tend to use much less acetaminophen right at the most critical time of life, which is right after you clamp the umbilical cord in the first couple of months, they apparently have a lower prevalence of autism spectrum disorder. And I understand the Israeli government has been trying to figure that out. So, uh, you've got an increase in prevalence of autism, just happens to correspond right when we switch from aspirin to acetaminophen because of
Mm.
concerns in the early 1980s about Reye syndrome, and then massive amounts of pharmaceutical marketing in the 1990s. You know, if you inflation adjust it, they spent more than twice every year what we spend on a modern blockbuster movie from Hollywood. Just advertising just acetaminophen. Yeah.
There is so much to unpack in those last few minutes of what you said. And if you're listening or watching this podcast, I suggest you rewind and listen again because there is so much evidence. And, you spoke to my membership group a little while back about this same thing. And we have all of that evidence listed in my membership, and it is readily available. And I'm floored by I don't think I remembered about the social awareness piece that research. I have to go back and read that article because I think that's fascinating. And, as you said, this has been decades. I remember lecturing about acetaminophen 20 years ago at a grand rounds and talking about not using it because of the problems with glucuronidation and others. So why do you stream medical centers, regulatory agencies, people in general, young people who are downing bottles of Tylenol after the HHA's came out and said there's research that it is toxic. Why do you think all of these places are disagreeing with you and others who are on top of it?
Right. Well, as a scientist, we monitor the scientific literature very closely. And
Okay.
just going back one step, so I just sort of gave you a stream of consciousness, and just kind of my consciousness just sort of randomly picks out. If we reround that video, we might find 12 lines of evidence that I mean, there's so many more out there.
Yeah.
For example, it's been known since the 1990s that in particular people with children, in particular with autism spectrum disorder, don't have either of the safe, they're impaired. It's, you can't say they don't have them, but both of the safe pathways are impaired specifically in those children. So there's a lot that we know that we've known. I think we probably knew enough in 2009 to say,
Okay.
wow, we need to change practice. That was 2009 was a pivotal year because nobody even
Yeah.
thought of the idea that acetaminophen could trigger autism until 2008. But then if you start looking back through time, you say, wow, there's a vast amount of evidence here, and it should have been enough in 2009. All right,
Yeah.
so back to your question. Now, why,
Yeah.
and this is a really fascinating question. So, and most of your listeners are going to know that maybe somebody at the White House made an announcement in September of 2025 about Tylenol not being safe and Tylenol being connected with autism spectrum disorder. So we've been monitoring the literature for decades, right? Or not decades. I've been studying immune dysfunction for decades, but for the last decade, we have been monitoring the literature very carefully, dealing with acetaminophen's connection with autism spectrum disorder. And what you see is that for a long time, there were just nobody was publishing on it until probably about 2013. And then there's a few papers a year, maybe 5, 6 tops a year. And then since September 2025, there's been 16 papers published on this.
Wow.
Yeah. And they're all saying the same thing, the exact same thing. So number one, they're focused on one line of evidence, and it's a line of evidence dealing with you get a big cohort or a big group of people, and it can be all the people born in a certain country, for example. Those are really popular, and you get good data from those. And then you analyze that and you look at the association between acetaminophen use and autism spectrum disorder. Now, the trick is there's two tricks to this. One is that they're only looking at pregnancy, and based on all available evidence, we're very convinced that it's when you clamp that umbilical cord, you no longer have the mother's liver there. You go from just really great metabolism of acetaminophen to really, going to use a pejorative term, really crappy metabolism of acetaminophen. So newborns are really not good at metabolizing acetaminophen. They are good at metabolizing breast milk, but not acetaminophen. So breast milk, of course, is already processed. That's the mother has taken care of that and produced that for the baby, who and our biology doesn't really need to have to worry about metabolizing a lot of what we call xenobiotics, or these foreign molecules
Right.
that are coming in. So if you look at those data, you still see an association between acetaminophen during pregnancy and autism spectrum disorder. And with heavy use, it's only about, say, a increase of 80%. And I say only 80%, but I mean, hang on, it gets a lot worse when you start looking at older ages. But so with heavy use during pregnancy, it's an 80% increase, but not that many people use acetaminophen heavily
Right.
during pregnancy, right? It's tops 10%. The big Swedish study, they only found 2%, but it's probably low because of the way they did the study. But it doesn't matter. The point is that it's about an 80% increase, but it's only a small percent of the population. But now, so we can go, and I'm just going to follow a little bunny trail. If you look at the time of
Okay.
birth, the associations are huge. If you look at regressive
Right.
autism, then the first study in 2008 basically said, hey, the common denominator with regressive autism is acetaminophen. So now let's go back to why everybody's distracted, or everybody's following a bunny trail that they shouldn't be on, right? So if you take that data at time of pregnancy and you adjust it and you take out all of the variables, including genetics, but not just genetics. When they say a sibling control study, it doesn't mean it's sibling control study. It means they've adjusted for dozens, literally, of variables related to susceptibility, and then they've adjusted for genetics by doing sibling controls. And what you prove is that if you're not susceptible, you're not susceptible. You won't get sick from acetaminophen. You won't get a
Right.
neurodevelopmental injury. But they're not interpreting it that way. Back in 2013, somebody said, hey, maybe these are confounding factors. They said the quote, potentially confounding factors. Doesn't mean they are, but then they started doing the math that way. And from a statistical perspective, you can't do that. And we could talk about the statistics. We published the paper, we modeled it. The bottom line is we showed if now we conclude this is true, but let's just do hypothetical for now. If acetaminophen triggers autism in susceptible individuals, then data that came out of Drexel University published, looking at the Swedish cohort, are exactly what we would predict them to be. So that's super important, but again, the situation is a little bit surreal. They need to listen to, you just need somebody with good, and our team, we have a toxicologist, we have a pharmacologist, we have, we worked with professional statisticians, and we have neuroscientists on the team. Yeah, they need to talk to a scientist that actually knows what's going on. And they published 16 papers, and some of them, and right now when I talk to a reporter, they're like, okay, what you're saying makes sense, but how can everybody be wrong? That is the
Right.
that's a really hard question to answer. I mean, if this is so obvious, which it is, how can everybody be wrong? And there's I have some insights into that, but those are more speculative, right? What we're talking about is a science, which is not speculative. It's concrete. So
Yeah, there are so many conspiracy theories and other things out there that I don't want to get into. I really do the clinician to follow the science. And I think the science is very, very clear here, as you say. But let me ask you, the what you're saying is that the greatest risk is from that time when the umbilical cord is clamped in that early developmental window, that first hours to couple of months, when the children cannot process acetaminophen. What you also said is that in Hasidic Jewish or other populations that may religiously do the bricks, they don't use acetaminophen at the time of circumcision, and those children are much less susceptible to autism. So again, another factor that sort of supports exactly what you're saying. But is that all correct?
yeah, that's all correct. We don't think the Jewish population is less susceptible. It's probably just they use.
Right,
And it's not just for
right,
circumcision that they don't use it. It's also they have, and there's a great paper that came out of a nursing school out of New York that just talks about in with Orthodox Jews even during labor and delivery. And that's, the data that are the most compelling in terms of associations. I mean, the toxicology, the animal studies, those are all clear, but those deal with
right.
cord blood acetaminophen and acetaminophen metabolites. So how much do you have exactly when the umbilical cord is clamped? And in the Orthodox Jewish population, they just tend to use less. It's not forbidden, but the practice
Right.
is that they use much less drugs than we accept in the Western community in general. So there's a
Right.
lot going on there, but it's the circumcision as well, which is separate from the Orthodox Jewish. That study is there's a one Danish study and one U.S. study that most people have missed. It's the U.S. study is not looking at autism; it's looking at social aversion behavior, and it's got a limited number of people, so they're not looking at autism, but what they're suggesting is something about the circumcision. And of course, we think that is acetaminophen use is causing an increased level of social aversion in general in the male population.
And one of the things you said the last time we spoke about this was it's like Occam's razor, which is the simplest explanation is usually the best, especially when comparing two comparing theories that explain the same phenomenon. Suggesting that the explanation requiring the fewest assumptions is most likely to be correct. Would you explain that a little bit more? I mean, I think that's so clear, but just explain that a little bit more to our
Right.
listeners.
So I think what is really a fun exercise is to look at all the evidence we have and say, okay, if it's not true, if acetaminophen has very little to do with autism or maybe only induces a few cases, it's rare, then what all else must be true? Right? And so then you have to start trying to explain all this evidence. Like, why was there this incredible, mine was 3.6 times more autism found in the women who had higher levels of acetaminophen in their cord blood, and the autism was found in their offspring. So, what is going on with that? And why did a guy named Stephen Schultz find that
Right.
acetaminophen was the common denominator in the regressive autism? And why does the Swedish group see these correlations before they adjust them out? Right? Why should that even be there? I mean, what's going on? And then there's a lot of evidence that we have that's looking back in time and looking at Grunya Sukareva, who first described autism in 1925, and then Leo Kanner and Hans Asperger, and those guys that are in the 1940s, and all of their colleagues accepted what they were saying, which means their colleagues thought it was rare. They thought it was rare. And, then there's early investigators in the 1980s without changing diagnostic criteria. And the diagnostic criteria, look, the hallmarks of autism are the same as were described in 1925. And we are much
Yeah.
better at detecting mild autism, but still about half the cases are fairly severe. So if that hasn't changed recently. So there's all of this other evidence you've got to try to explain. So this idea of Occam's razor. So if you've
Yeah.
got one clean, solid explanation, everything makes sense, everything fits together, boom, perfect, versus the alternative, which is now you've got this laundry list that is more than 16 items long of things you really can't explain, or you just have to, it's called a post hoc explanation. You just have to make up stuff with no evidence that this must be due to this or this must be due to that. So which as a scientist, you pick the one that makes sense. Now so that that is that you have the evidence for, right? You don't pick the other one just because you don't like the one that you have the evidence for. So it's important, I think, to keep in mind that this drug, so far as is known, is not life saving. So it sort of
Right.
reminds me of thalidomide, right?
Yeah.
Thalidomide is the greatest drug in the world for morning sickness, from what I understand. And morning sickness is not a fun thing, from what I understand. I've never experienced it, and I think that'll be obvious to your audience. But the bottom line is you can't use it. So
Right.
because it causes severe adverse outcomes, right? And if it's not life-saving, then the question is, if it's not life-saving, it's causing severe adverse outcomes, how certain do we have to be that it's causing severe adverse outcomes? Now, and then the answer is obviously, yeah, we knew enough in 2009 to have done something about this. But going back to your earlier question, if everybody is off on this bunny trail following this sibling control study, which again gives exactly the results that we predicted should give if we're right, then
Right.
we're sort of stuck. And that's, and every time I go through and I show people the data, this is how it works, and we publish the papers on this. And, I have a background in education, right? Almost 30 years at a university, and then I've taught scouts for even longer than that, right? So, every time I teach, every time I explain this, it makes sense. And be like, yeah, yeah, okay, that's cool. But, it just hasn't gotten into the mainstream. Again, really a surreal situation.
Yeah. And for a minute to that Stephen Schultz article, that was in 2008. And he showed that acetaminophen use itself, regardless of vaccination, was strongly associated with regressive autism, correct?
That is correct. Yeah, the odds ratio was over 20. So,
Yeah.
I mean, that's
Yeah.
not 20%, right? That's a factor of 20. So, and
Right.
when we talk to, I just wrote a book about this. It'll be coming out in April. And, I interviewed people and like, oh yeah, well, we use, and one couple I interviewed had given their child over 1,000 doses of acetaminophen because it adds up, right? Because every time they have an ear infection, every time they get a vaccination, every time they have a cold, if you give it to them around the clock to make them more comfortable because it's the right thing to do. You've been told it's the right thing to do. So that those add up. And then of course there's the infantile autism, which probably can be triggered by, based on the data out of Johns Hopkins with the cord blood, probably by a single exposure because you're more sensitive at that time.
Right.
Whereas regressive autism, those are usually involving more treatments. And I'm not saying that a single treatment at age 2 is safe, but I'm saying generally what we see is that it's repeated treatments, say at the median time to regression is about 18 months of age. So, you're seeing repeated treatments for some kind of ongoing condition associated with regression.
So we know that it's from multiple studies, 22, 30, multiple, that it's harmful for neurodevelopment. We know that there are a group of children that are genetically susceptible due to decreases in needed detoxification, glucuronidation, et cetera. Studies have failed to demonstrate long-term benefits of acetaminophen. So, in my opinion, there seems to be no valid rationale for continued use of this drug in those children. Is that correct? Like,
Yeah, we published a really, really, I think, good paper in the
yeah,
flagship journal for the Korean Pediatric Society, and it was sort of there's no valid rationale for this controversy because the apparent adverse effects outweigh the known benefits. So yeah, it's a really just difficult. It's very difficult if you want to try to justify using the drug. I mean, and the bottom line is you can say that no studies have been done. So that's the best you can do. If you really want to use the drug, you can say, well, maybe that for an occasional fever during pregnancy, when the odds ratios are before that invalid adjustment, the odds ratios
right,
are very low for occasional use during pregnancy. And our thinking is that maybe if you use it occasionally during pregnancy to treat a fever, it might have a net benefit, but or it might not, but we just don't know. The studies haven't been done. So there's some things, we have to be clear about what we know and what we don't know. And we know that heavy
right.
use is associated during pregnancy is associated with an increase that's pretty appreciable in the prevalence of autism. But we don't, again, that's just an association. It doesn't prove causation. What does tell us that causation exists is that whole body of evidence that we have, but we don't have that whole body of evidence doesn't apply to pregnancy. So we're just not as sure about what goes
Right.
on in pregnancy. We're really very certain about what goes on at the time of birth. So the obstetricians need to know this information desperately. And
Yeah.
then the pediatricians need to know, as far as the gynecologists who are treating pregnant women, the studies haven't been done. I would say that women should be informed, but we can't absolutely say that it's definitely bad, especially with occasional use.
Okay. Okay. But let's say, we have a mom with pain, fever. It's not occasional use. This happens more than once in pregnancy. In pregnancy, what do you recommend for the treatment of pain and fever? That's
Well,
a question that comes up all the time.
as you know, my patients they all weigh about 1 pound and they have fur. So, it's not because they have a birth defect, it's because they're not human. So I'm not allowed, I will let you give that advice.
I
But what
get
I
it.
will say is that if what we do say as scientists, our job is to inform. And so I would say, okay, all right, well, here's what we know. We know that with occasional use, the odds ratios, the increase in which is just an association, doesn't prove causality, is pretty low. With heavy use, say for treatment of pain, chronic pain,
Yeah.
that's going to be a much higher ratio, right? And then we sort of know this laundry list of factors that cause susceptibility. So you could try to, we know all of this stuff, but we can't tell a mom what to do. We definitely know that, for example, for labor and delivery, where maybe around that time, very early in life, in the first hours to weeks, probably half of all cases of autism are induced. We know that you just shouldn't be using acetaminophen. That especially during labor and delivery, where acetaminophen does not
Right.
effectively treat the pain of that process. So but everybody keeps zeroing in on what we don't know, which is okay. I can answer the question, but it's like I think we really need to get the low hanging fruit first, which would be obstetrics, which would be pediatrics. I mean, we know, the regression, it's 30 to 40% of all cases of autism. So they have some
Right.
elements of regression. So that's a lot that can be dealt with just right off the bat. And then I think if women are informed, I interviewed for this book that I just wrote, I interviewed one woman who said, okay, I had 3 kids with autism and I heard about the work and I decided, okay, I'm going to have a 4th kid with no Tylenol. And she said it was hard. It was hard, but she has one neurotypical kid. And of course, that's an anecdote. As a scientist, we hate
Right.
anecdotes. But the point is that, this is sort of the idea of what you do. You inform people and then you let them make their decision. Right?
Right.
It's not a guarantee that they won't have a child with autism, but our conclusions are, you can look at the science and see how solid they are and then decide what the parent decides what they want to do.
Yeah. Well, people ask me all the time about the use of ibuprofen, NSAIDs. Now, I can't speak to obstetrics, but I can in pediatrics. And I think, especially in PANS PANDAS, there's very good research that NSAIDs are much more helpful than acetaminophen to start with. So, what about the use of ibuprofen? Do you want to speak on that at all in
Sure,
any
yeah.
group?
So I would people ask me, well, what are you going to I am a biochemist. I'm PhD in chemistry, specialization in biochemistry, biophysics, work with other like real sciencey nerd people. I mean, my wife buys me these clothes, but normally I wear cargo pants, right? I'm just a normal nerd, right? So I really do understand how acetaminophen works. I know a lot about how it induces neurodevelopmental disorder. But if you want to, people keep asking me, well, what do you do instead? I'm like, whoa, first of all, it's a completely different set of expertise to understand treating pain versus treating fever, right? One of them I mean, they're 2 different medical disciplines, really, right? One's infectious disease and the other one's neurology. So and none of those are my expertise. So, I mean, this is my comment though. My comment is when I go to a major medical center, they say, oh my gosh, what are we going to do if we can't use acetaminophen? And there's sort of a horror look on their face. When I go to a functional medicine conference, they're like, no, I don't need that stuff. So, it's a really dramatically different perspectives. And there's no research, from the science nerd guys, right? And my team, they're like, well, there's no research on that. But when I talk to doctors, right, I get really different perspectives. And talking to doctors is not science anyway. It's just something that I end up doing because of my job as a scientist. And it's my observation is that a lot of doctors know exactly what to do and haven't been using acetaminophen for a long time, but not a lot of doctors in the mainstream institutions.
Right, right. And as one of those in functional medicine who hasn't been using it for quite a long period of time, there are many alternatives. As a parent, I can understand how hard it is to watch your child have a fever. But as a practitioner and as someone who likes to appreciate and understand the science, fever is a good thing. Fever means your body is fighting that infection. We don't necessarily want to suppress a fever, and we can help a child to feel more comfortable with tepid baths, Epsom salt baths, good old chicken soup, lots of fluids, turmeric and other herbals, feverfew, things like that. There are many, many things we can use. And there are many other things that we can use for pain that are either topical or homeopathic or herbal. So there are a plethora that are out there in our children. I don't want to speak to the obstetrics of it, and I will have somebody else on speaking to that in the future. But there are a
Right.
lot of options in pediatrics. And I think that's a message that I want to bring to my patients is let's look at all those other options. When your pediatrician is saying just give Tylenol or alternate between Tylenol and ibuprofen or give Tylenol after the vaccination, let's step back. I have a whole handout on what else we can do besides that to help our children. But don't forget that fever is not a bad thing, especially, in slightly older children. We have to let the body use its own natural mechanisms for fighting infections and intoxicants, etc.
Yeah, we have done our homework on that one, and of course, the fever is a natural part of the immune response. When you suppress a fever, you're immunosuppressing a patient. So even cold-blooded animals have a ways of elevating their temperature when they get an infection. It's part of their biology. So yeah, I think you're doing a great job with working with alternatives. If I ask somebody in the mainstream, they're going to say, "Well, those haven't been tested," and I can flip that around and say, "Well, you didn't test acetaminophen for neurodevelopment either." So,
Yeah.
you don't want to I mean, right now we just have to go forward as best we can given the information we have. You don't want to put on the
Right.
defensive saying, well, that hasn't been tested. And sure, acetaminophen has been tested. It does have an effect on some types of pain and definitely on most fevers, perhaps not many of the very dangerous fevers. And, but we're stuck in a situation with these alternatives. As a scientist, you throw up your hands and say, I this doctor, I believe she knows a lot, but I use the word believe, which scientists don't like, but I don't have any proof. So
Yeah.
that's where my answer is.
Yeah. And just one more piece on this, which is, this is the Demystifying PANS Pandas podcast. Although we talk about autism because I think there's a lot we can learn from those canaries. I grew up in West Virginia. We sent canaries into the coal mines. If the canaries died, that meant it was too toxic for the miners. That's our children with autism are that group of susceptible children. But those with PANS Pandas or those with autism and PANS Pandas also have some amount of genetic susceptibility, which we're not totally understanding either. But I can extrapolate partially because of your session of the study on social awareness that those children may in some ways also be affected by acetaminophen, and even at 6 and 12 and when you're not as susceptible as that newborn that we're talking about, it would be a good idea to avoid. Agreed, or any comments on that?
Well, so there's some studies in mice, and we've seen this in rats, although since September, for some reason, it's harder to publish our work. And there's some evidence in humans that if you get an injury from acetaminophen, your body sort of adjusts and you become less sensitive
Mm,
to the effects of acetaminophen. So in other words, acetaminophen stops working as well for its intended purposes. And that seems to be it's somewhere between, in modern science, a hypothesis, just an educated guess, and then you got sort of working model. Seems like we've got some data behind this, and it makes sense, and it looks reasonable. And it's not, I wouldn't say a firm conclusion. It's not that far, but so that's one thing to consider, that if a child has been injured by acetaminophen, it just might not work as well.
got it. Okay. For those in my membership, there's a tremendous amount of this information there, a lot of the research that William has talked about. And you also mentioned, William, there's a website, preventautism.org. Could you tell them
Right.
what they'd find there?
Yeah, preventautism.org will just have it's broken down into sort of, for scientists, you can just go straight to the papers, and I need to update that with the stuff that's forthcoming, but it's right now it just has the stuff we've already published. And then it's got stuff that's just really written that anybody can understand it, and that it spells it out. It I think the hardest part right now is so many papers coming out just saying there's no problem with this, and all focused
Yeah,
on one line of evidence, looking at the wrong time period, using an analysis which is good, but it's not showing them what they think it's showing them. I mean, that's the hardest part, is to get past all that. And if you get past all that, then I think parents will know enough, and physicians, unfortunately, a lot of physicians are in a spot where they have no choice. right? They're in a major medical center, and if you don't treat that fever with that drug, then you will get in trouble with your supervisor.
Right.
So, but a lot of physicians are in a better position, fortunately, and have some flexibility with their practice. So I think
Yeah.
we have enough information out there for those physicians and those parents. The problem then comes in when you've got an inflexible administration in a major medical center, which just doesn't give the physicians any options.
Right. Right. So preventautism.org. And do you have a name for the book that's coming out?
The name for the book is Tylenol and Autism, and then there's a colon, right? And it's evidence. And let's see what comes next. It's evidence. Um, and then the last part of it is medicine gone wrong, but there's something in between there, that it's something about mistakes.
Okay. All right. I'll look for it. Tylenol and Autism. Uh, it will be a great book, and preventautism.org, lots of information there. And William, one of the reasons that I trust you so much is because I learned how much you know about the body, the science, through your work with Hellman therapy, and you have taught me so much about a word I couldn't even pronounce, let alone know what it is, hymenolect immunocystocercoids. As I said, it took me a month to even pronounce it. But I would like to spend just a few minutes because I do think this whole idea of immune tolerance and autoimmunity is very important for our group of PANS pandas. So I want to digress from the acetaminophen for a minute and just take a few minutes to talk about Hellman therapy and HDCs, which is how I got introduced to you and all the research you had done many years ago on that and all your furry friends. So could you just take a few minutes and tell people what that is, why it works, and why it's such an important thing for people with autoimmune disease?
Right. So to really understand helmet therapy, I think we need to go back to 1968. There's a guy named Brian Greenwood. Everybody, and I say everybody, this is my talking with Greenwood. So this is secondhand information. He's still alive today. He's retired,
Wow.
obviously, but he was a brand new medical doctor, he was British, and he was posted to Africa. The thinking was at that time that, look, we think that they have a lot less autoimmune disease in Africa than they do in the UK. You just can't find it anywhere, but we're not sure. It's almost the same thing here with autism today is that, well, maybe it's there, but we're not surveying for it and finding it. So what Greenwood did when he got to Africa was he did two things. First of all, he went out and actually boots on the ground, did the survey. He's like, nope, they don't have it. And he looked at rheumatoid arthritis, I think.
Yeah.
And so the bottom line was they don't have it. And then second thing he did, he's got a bunch of mice. He's in Africa. So this is in the old days. So basically you take your lab mice home with you on the weekends just in case the generator shuts down on the animal facility. So this is old school science, right? But he shows that you can cure he had these mice, and they still use them at Duke. It's a really popular model that have lupus, and he showed that nope, if they have an intestinal worm, they won't get lupus.
Yeah.
So, and then other people have looked at inflammatory bowel disease and, a variety of other, multiple sclerosis in particular, and so on and so forth. But the bottom line was everybody in 1968 knew, well, if they have less autoimmunity in Africa, well, it must be due to this one big change in our biology, which is we've lost all these, we call them complex eukaryotic symbionts. So basically intestinal worms. So we've lost the
Yeah.
big boys from our gut and big girls too. It depends on some of them are boys and girls all in one worm. But anyway, the bottom line is that we've lost them and it's caused fundamental changes in our biology. So there's whole swaths of cells that we have in our body that have nothing to do. And for about 400 million years, probably going way back before our ancestors were human, those immune cells, I mean, they had something even before T cells and B cells became two different things, right? There were still these organisms and our immune system was dealing with them. And suddenly, after 400 million years, poof, they're gone because we
Yeah.
invented toilets and sewage systems and
Yeah.
plastic containers and refrigeration.
Yeah. And
This floor
shoes
I'm
and
on,
all of that.
yeah, it has a wood floor. My feet will not touch the ground. Even if I go barefoot all day, my feet will not touch the ground. So I basically can't get any of these organisms now, even they're gone. They're not even out in the soil now because we've lost them in this part of the world. So fundamental changes in biology we've known since 1968, 1970. And then Peter John Preston, another British doctor, he was posted to India working for the army. And what he found was, hey, my soldiers who have seasonal allergies, if they get a worm, they complain a lot because it was a giant roundworm. It's not a good worm to get. But he said they complain a lot, but their seasonal allergies go away. What is up with that? That was published in 1972. And he wrote the beautiful paper on it and just said, well, this is what's causing seasonal allergies. We're just missing these worms. And he treated his soldiers for the worms. And then after a period of time, their seasonal allergies came back. And he had a control group. And just going to India doesn't make your seasonal allergies go away. You have to go to India and get a worm, makes your seasonal allergies go away. We've known this stuff for a long, long time. So the idea behind helminth, and helminth is just a fancy word, right, for an intestinal worm. And obviously, we want to pick an intestinal worm that nobody can pronounce, nobody's heard of it, because it doesn't do any harm, right? The ones that really harm people. I mean, okay, so there's a whole different thing about you can use them in moderation, but there's a kickback and so on and so forth. But we'd rather pick a really benign one that doesn't have any bad effects, that just sort of swims around the gut, doesn't dig into the gut. And that's the Hymenopus diminutus citrus records that you're talking about. And those you can control the dose exactly. And unfortunately, those have not yet been tested in clinical trials. If we get them tested in clinical trials, then, and we're working on that. That's one on my bucket list. I really hope to do that. But if we do that, then it'll be everywhere. They work great. They do work great for seasonal allergies, and they help a lot with these kinds of chronic immune dysfunctions. And the data that we collected while I was at Duke, looking at interviewing people that are using them to treat various conditions, indicate they work really well for some patients with PANS and PANDAS, and even some patients. So the hallmarks of autism, the neurological effects, the in particular, the lack of social awareness, it's not affected by a helminth, right? That's a
Right.
neurological injury. It doesn't change neurological injuries, but it does affect chronic inflammation that affects so many children with autism and the children that you work with.
Right. Absolutely. And children with alopecia areata, children with inflammatory bowel disease, a lot of other autoimmune diseases. And as you know, my mentor, Dr. Sidney Baker, was the person that introduced you. I always fascinate. I love hearing the history of the science behind it, the people in 1968 like Greenwood that were talking about it. And it's such a juxtaposition for me because that's where Sid trained. That's where Dr. Miller to Sid, Sydney, have we done enough for this patient? And that's what I live my life by, always looking. And that's where for me these HDCs come in. You know, if we're not decreasing the inflammation with things other than acetaminophen, if we're not helping the child with their immune system, thinking about HDCs, thinking about this type of helminth therapy, may well produce or be part of that development of immune tolerance. So, um, it's another fascinating field of study, one that you and I have talked about ad infinitum. And I hope that more study is done because I think we spend a lot of time talking about parasite cleanses and getting rid of parasites, but that diversity of flora includes parasites and they need to be part of us, correct?
Well, so by definition, and
Okay,
this
go
is
ahead.
one of the things that we're always on
I
top
hear
of,
you.
right?
I know what you're
Right.
gonna
You know
say.
what
Go
I'm going to
ahead.
say. By definition, a
Yeah,
parasite is something that harms the host. So we
right,
don't want to pick, and in fact, a parasite by definition has a net harm for a host. So let's say you're dying from multiple sclerosis because you're in a part of the world where you can't get modern medications or then they're still so expensive or you don't have insurance. And so a few hookworms, they might give you some stomach upset, but they might halt the progression of your relapsing and remitting multiple sclerosis. And based on the data we collected while I was at Duke, that is they will if you take the right number. So in that case, the hookworm it's not by definition a parasite, but of course, if you've already got 20 other worms and you're super
sure,
sick and you're at the edge of starvation, and then if you get 200 hookworms, that's not going to be a good thing. Then it's definitely a
right.
parasite. It might actually kill you. So the But with the Hymenopus, what you're doing is you're picking an organism which is almost never a parasite,
Right.
right? And especially in humans,
Right.
because it doesn't gain any benefits by being in the humans. It tends to have, as long as it's used in the right amounts by somebody who knows what they're doing, then it tends to have a beneficial effect or no effect. It's rare that it has an adverse effect. And I think most people are learning when it does and how to identify that in advance to avoid it.
Right. Absolutely. So if you want to learn more about Hellman therapy, you can go to a website, biomerestoration.com. There's more information on the blogs on my website and much more information in a lot of the articles that Dr. Parker and others have written. If you want to learn more about acetaminophen, wait Tylenol and autism, or check out preventautism.org, or again, in my membership, there's a lot of information there. Oh, William, I so appreciate all of the science that you bring to us with the ability to help us understand it, as well as just the integrity and compassion that you show every day. So, any last words you want to leave our listeners or viewers with?
I would say that, when it comes to the acetaminophen autism connection, we have a website. If you have questions, the website is there. Clinicians contact me on a regular basis. I think when most people look at the evidence, they don't really have any questions. But if one does come up, it's fairly obvious where everybody's missed it. And, when you're a scientist, and you disagree with other people, when you know you're right is when you can see exactly the mistake that the other person has made, and you can prove that it's a mistake, which is what we've done. We've run the calculations, run the simulations, shown the math, basically. So I don't think people have a lot of questions, but if they do, they definitely were available. They should contact us, and we're happy to help.
Well, thank you. You've helped me so much over my career, and you are helping so many of the children and families just by doing the research that you're doing and continuing to pursue what may be, an unwelcome view in the traditional medical community. So we so appreciate
Maybe,
it.
maybe.
So,
Thank you.
well,
Thank you, Nick.
thank you, William.
Yes, ma'am.
All right. Have a great day, and we'll see you next time on Demystifying PANS Pandas. That's it for today's episode of Demystifying PANS Pandas. I hope you're walking away with insights, tools, and hope to help you and your child on this journey. If you found today's conversation valuable, be sure to subscribe so you never miss an episode. Share this podcast with anyone who might need it. It could be the lifeline they're searching for. And if you have a moment, leaving a review helps us reach even more families who deserve answers. Also, for more information, training, and community, check out our website, drohara.com, and join our annual membership. And remember, every step forward, no matter how small, brings us closer to healing and understanding. Until next time, be present, be hopeful, and we look forward to seeing you next time on Demystifying PANS Pandas.